This is a presentation about acute liver failure. Here are our objectives. In this presentation, we will be discussing about the normal liver function, the pathology of acute liver failure, two of the causes, treatment options, and nursing implications.
The liver is the largest visceral organ in the body. It is located below the ribs, primarily in the upper right quadrant while reaching into the upper left. The liver is comprised of 4 lobes. On the anterior surface is the large right lobe, which is separated from the left by the falciform ligament. On the posterior surface is the caudate lobe, separated from the right lobe by the inferior vena cava. The 4th liver lobe is the quadrate lobe, located inferiorly to the caudate lobe, below the left lobe in the gallbladder. The gallbladder is found on the posterior surface of the right lobe. The main blood supply to the liver is through the hepatic arteriole proper, carrying arterial blood, and the hepatic portal vein, carrying venous. The liver is comprised of many functional units called lobules. The lobules are made up of liver cells called hepatocytes. It is a vascularized area divided by plates containing sinusoids, allowing for movement of solutes within. Kupffer cells exist within the sinusoidal lining, which are phagocytic cells that engulf pathogens, cell debris, and damaged blood cells, as well as storing iron, lipids, and heavy metals. Portal areas refer to the structures within the lobules, which contain a branch of the hepatic portal vein, branch of the hepatic artery proper, and a branch of the bile duct. The hepatic portal system has a normal low pressure. Portal hypertension is caused by a pathology that reduces blood flow, causing the vascular components to descend with the possibility of rupture, as well as causing fluid to move into the peritoneal cavity. The liver has many different functions which can be classified under metabolic regulation, hematological regulation, and bile production. Metabolic regulation includes carbohydrate, lipid, and amino acid metabolism, waste product removal, vitamin and mineral storage, as well as drug inactivation. Hematological regulation includes phagocytosis and antigen presentation, synthesis of plasma proteins, removal of circulating hormones, removal of antibodies, removal and storage of toxins, as well as the synthesis and excretion of bile. Lastly, the liver is responsible for bile production. The above mentioned are some primary functions of the liver. However, the liver has countless other functions, as well as influences other bodily systems. Due to the wide-reaching functions of the liver, there are numerous tests that can be used to gauge liver function. Some of the primary laboratory tests for the liver are albumin, which is a protein produced and synthesized in the liver, which is primarily responsible in regulation of oncotic pressure. ALT is a liver enzyme released in response to injury of hepatocytes. Ammonia is produced in protein catabolism and transformed in the liver to urea for kidney excretion. AST is an enzyme found in high concentrations in response to hepatocyte damage. ALP is an enzyme found in Kupffer cells. It's related to biliary functions of the liver. Bilirubin can be total or conjugated based on the level of transformation it has undergone. It is produced in the breakdown of heme and eventually excreted by the liver. GGTP is an enzyme connected to amino acid transfer. It is found in large quantities in the liver. 5-NTD is related to damage to the biliary system. Coagulation tests may reveal hepatic dysfunction as the liver is involved in the production of coagulating factors. Glucose is implicated in liver disorders due to gluconeogenesis. Exploratory and visual tests can also be done to provide a view of the dysfunction related to physiology of the liver and related structures. Please refer to the video in the comments section titled "The Anatomy and Physiology of the Liver" for a brief overview. Fulminant hepatic failure and acute liver failure are most commonly used synonymously. However, in some texts, fulminant is distinguished based on onset of symptoms, specifically those of rapid onset. FHF is defined as a multisystem disorder in which severe impairment of liver function, with or without encephalopathy, occurs with hepatic cellular necrosis in a patient with no reported underlying chronic liver disease. Although it is uncommon, the implications are severe, as the disease has a high mortality and is very costly to treat. Studies cite up to 80% of cases caused by acetaminophen toxicity may result in death or liver transplant. Liver cell necrosis impairs glycogenolysis, gluconeogenesis, and insulin metabolism. The commonly used classification system suggested by O'Grady et al. Refers to three presentations of the disorder: hyperacute, acute, and subacute. They are differentiated by the interval between jaundice and encephalopathy, presence of cerebral edema, and the prognosis. The key features of the disorder are severe hepatocellular injury, jaundice, and hepatic encephalopathy. In making a diagnosis of FHF, some definitive symptoms include increased AST, bilirubin, ALP, PT, INR, and hypoglycemia. Early symptoms include fatigue, malaise, anorexia, nausea, abdominal pain, and fever. Complications and comorbidities include encephalopathy, correlated with cerebral edema and intracranial hypertension, which is a neurologic condition related to high concentrations of neurotoxins in the blood. Coagulopathy is related to the liver's role in synthesizing coagulating factors and their inhibitors, leading to dysfunction and blood clotting. PT measurement is suggestive of severity of FHF. Infection and sepsis. Infection is found in up to 80% of patients with FHF, bacteremia in 20 to 25%. Dysfunction in the mononuclear phagocyte system, specifically Kupffer cells in the liver. Decreased antibody production and recognition leads to decreased defense against bacteria and opportunistic organisms. Metabolic abnormalities include acute renal failure, electrolyte imbalances, hypoglycemia, and pancreatitis. Renal failure develops in up to 40 to 50% of FHF cases and up to 70% in acetaminophen overdose. Cardiorespiratory and hemodynamic complications progressing to cardiopulmonary collapse and multi-organ failure. Implications of systemic vasodilation, low systemic vascular resistance, hypotension, and increased cardiac output. Jaundice is an expression of the high levels of bilirubin present in the bloodstream as a result of the liver's inability to transform and excrete it. The hallmark of jaundice is the yellow discoloration it causes in the sclera in the skin. Hepatic encephalopathy, also known as hepatic coma, is a neurologic condition related to high levels of neurotoxins in the blood system of individuals with FHF. This is related to dysfunction of the liver to filter out said toxins. A primary molecule implicated is ammonia, as it is transformed and metabolized by the liver. This is a cornerstone of FHF and can be measured in severity based on the mental status of the individuals, presence of tremors, and abnormalities in EEG. The toxicity caused by liver dysfunction can lead to a cascade of cerebral comorbidities, such as the aforementioned hepatic encephalopathy. Hepatic encephalopathy is correlated with the development of cerebral edema and intracranial hypertension, which are both life-threatening conditions in themselves. Cerebral edema in FHF is the swelling of brain tissue resulting from the neurotoxin imbalances, similarly thought to be the cause of hepatic encephalopathy, and retention of fluid from high concentrations of solutes. As the brain swells within the skull, there is little room to expand, and thus intracranial hypertension may result. This is a serious condition that is implicated in 20 to 25% of mortality cases. There is also a link between the body's inflammatory response and the hepatic encephalopathy, as well as the resulting cerebral edema.
These are some causes of acute liver failure. This list is not exhaustive. I will now discuss the causes of failure by acetaminophen.